Good morning. Thank you, Rashmi. Very briefly, over the next 10 minutes, I would like to discuss this rather distinct clinical patterns of refractory systemic juvenile idiopathic arthritis. I think we all agree that the, just one second. I think we all agree that the introduction of the IL-1 and IL-6 inhibiting biologics dramatically changed the long-term outcome of systemic juvenile idiopathic arthritis for the vast majority of these patients. However, at least 20% of these patients do not respond to the existing treatment very well and develop a refractory disease course. They typically fail to respond to the approved biologic and non-biologic disease-modifying anti-rheumatic drugs. And most of these patients continue to have persistent disease activity requiring maintenance therapy with high-dose glucocorticoids. We think that there are at least 4 distinct clinical patterns of refractory disease in this population that certainly may overlap with each other. It includes refractory SJIA with persistent arthritis, refractory SJIA without arthritis, refractory systemic JIA with chronic parenchymal lung disease, as well as refractory SJIA with relapsing macrophage activation syndrome. And this group actually may include a very interesting, very perplexing subtype of SJIA, and it's a group of patients with predominantly liver involvement. And most of these patients, unfortunately, particularly those without arthritis, do not meet the eligibility criteria in the ongoing clinical trials in systemic juvenile idiopathic arthritis. Now, very briefly, I would like to go over each of these clinical patterns. So we'll start with refractory SJIA with persistent arthritis. Perhaps this is the least challenging group of the 4. Again, these patients do have arthritis. As a result, they usually meet all the diagnostic criteria for systemic juvenile idiopathic arthritis. And in general, they are eligible for the ongoing clinical trials. The main challenge in this patient population is the background medications. Again, it's a refractory disease. Most of these kids are on multiple biologics and non-biologic DMARDs. And the question how to handle that heavy medical treatment at enrollment still needs to be defined. The next group of patients is much more challenging. Those are patients with refractory systemic juvenile idiopathic arthritis without arthritis. These patients tend to have prominent and persistent systemic features. Many of them have somewhat atypical rash and atypical fever pattern. The rash is sometimes very pruritic, looks sort of urticarial and reminiscent of some inflammatories. These patients also tend to have more prominent hepatosplenomegaly and lymphadenopathy. In our experience, these patients tend to have higher rates of macrophage activation syndrome, and clearly they tend to have higher levels of serum IL-18. In fact, in some of these patients, the levels exceed 100,000 picograms per ml. And when I see those patients in my clinic, I'm often wondering whether, in fact, I'm dealing with some kind of a IL-18 mediated inflammatory. But when we go ahead with the genetic testing, usually it's unrevealing. So these patients are very difficult to enroll in clinical trials for several reasons. First, due to the absence of arthritis, we cannot diagnose them with definitive systemic juvenile idiopathic arthritis. And as a result, they are not eligible for the ongoing clinical trials in systemic juvenile idiopathic arthritis. Due to the absence of a genetic diagnosis, we also cannot enroll them in the ongoing clinical trials in inflammatories. And I'm specifically referring to the clinical trial of the bispecific monoclonal antibodies that neutralize both IL-18 and IL-1 at the same time in patients with the NRSC4 gain-of-function mutations. The other challenge in this group of patients that if you think about the existing outcome measures, and I'm specifically referring to the ACR-JIA response criteria, they are all focused predominantly on the arthritic component of the disease. And the outcome measures for the systemic component of this disease in general are not very well defined. We think that the sort of potential options to improve that might include modifying the existing ACR-JIA response measures. Another option would be to apply the autoinflammatory disease activity index, or the option that I would prefer personally would be to improve the existing systemic JADAs that perhaps could be modified to, again, better reflect the systemic component of the disease. The next clinical pattern is refractory systemic juvenile idiopathic arthritis with chronic parenchymal lung disease. As a group, these patients tend to present with the first signs of SJIA at a younger age, usually before the second birthday. They typically have prominent and persistent systemic features and less arthritis, if any, in fact. About 80% of these patients have a history of macrophage activation syndrome, usually recurrent. About 40% of these kids show some strange reactions to biologics, predominantly tocilizumab. And many of these patients develop this sort of very peculiar pruritic maculopapular rash and peripheral eosinophilia, raising concern for some kind of a hypersensitivity reaction. Again, in general, these patients tend to have very high levels of IL-18, and those levels rise even higher with disease flares. The prevalence of this pattern can be as high as 7% of the SJIA population, at least in the United States. I'm not sure whether this number is similar in Europe. I think it's much lower. And the other major challenge with this patient population is the fact that the clinical features of this particular complication become apparent relatively late in the course of the disease. There is a striking dissociation between relatively mild clinical findings. Usually these kids start with only mild tachypnea with activities and perhaps some clubbing, and the massive changes on the high-resolution chest CT investigations. Here in this slide, I try to summarize those changes. These patients typically start with subpleural thickening, consolidation with bronchiovascular-centric tree and bud opacities. Then we start seeing intralobular septal thickening, ground glass opacities, and eventually areas of consolidation in more severe cases at the later stages of the disease. Histopathologically, this type of lung disease is very distinctive. Typically, we see this patchy but often extensive lesions comprised of mixed features of pulmonary alveolar proteinosis and endogenous lipoid pneumonia. The other striking feature is this sort of massive interstitial expansion by lymphoplasmacytic infiltrate that includes lots of T cells. We also see quite a bit of pleural and intralobular septal collagenous fibrosis. The vasculopathy is prominent, very prominent in many cases, and it may lead to pulmonary hypertension. And the other interesting feature is certainly the presence of strong interferon-induced and T cell activation signatures in gene expression studies utilizing tissue biopsies from these patients. Another striking feature is that, as I mentioned earlier, these patients are distinguished by high serum levels of IL-18, but we also find high serum levels of IL-18 in the bronchoalveolar lavage from these patients. Again, these patients are very difficult to enroll into clinical trials. First of all, the absence of arthritis in a large proportion of these patients precludes a diagnosis of definitive systemic JIA. All these patients have numerous background medications that may be difficult to handle at enrollment. And the other major issue here is that the outcome measures for the lung component of the disease are not very well defined. The next pattern are patients with systemic juvenile idiopathic arthritis with relapsing macrophage activation syndrome. If you sort of think about patients with MAS in general, we think that this pattern occurs in approximately 5% of patients with a history of macrophage activation syndrome. These patients sort of present with this sort of frequent, often continuous episodes of MAS. At each time point, they certainly show features of some laboratory features of macrophage activation syndrome, but do not fully meet the classification criteria for MAS. Again, these patients tend to have very high levels of serum IL-18. They appear at a high risk for the lung complications seen in systemic juvenile idiopathic arthritis. And there is also another sort of very perplexing group of kids who have predominantly liver involvement. And this pattern is sort of very, very easily recognizable. These patients have persistently elevated liver enzymes with laboratory features, again, of subclinical MAS, but they do not meet full criteria for MAS. The histopathologic findings in this population and liver biopsy actually are very, very characteristic. We typically see sinusoidal inflammatory infiltrate. It consists both of increased numbers of T lymphocytes, predominantly CD8 positive lymphocytes, as well as CD163 positive macrophages. We see highly activated Kupffer cells, with many of them exhibiting overt hemophagocytic activity. And again, if you look at the T cells in these patients, we see a marked predominance of cytotoxic CD8 cells over CD4 positive T lymphocytes. And immunostaining for cytokines typically identifies CD8 positive T cells as the main producers of large amount of interferon gamma in the liver. And interestingly, most of these patients may have a normal bone marrow biopsy. This is a sort of a figure from a patient published by Karin Wouters many years ago, again showing typical liver biopsy in this patient population, showing again activation of macrophages producing pro-inflammatory cytokines. Many of them exhibit hemophagocytic activity, and large numbers of CD8 positive T cells producing interferon gamma. And again, a very similar pattern was recently described by Fabrizio's group. 3 patients with exactly this clinical pattern. All those patients had very, very similar histopathology. And the gene expression studies in the liver of these biopsies identified massive production of interferon gamma. Again, these patients are difficult to include in clinical trials. It's a relatively rare phenotype, and I don't think it's feasible to perform a separate clinical trial that would be focused specifically on this patient population. And the question is there a way to include them as a subgroup in some kind of a larger basket trial? So again, that's, I think, my last slide. So these are clearly distinct but overlapping clinical phenotypes, difficult to enroll, and I would say probably the unifying feature between all these clinical trials is high levels of serum IL-18. Thank you, Rashmi. That was my last slide.